Hello, I'm Bob Meeker. I'm the Director of Innovation from a group of CCGs in North East London, Barking, Dagenham, Havering and Redbridge. I've broken this webinar down into 4 specific sections so that it can be reviewed later on as you see fit. But I'll start with the introduction. So the Barking, Dagenham, Havering, Redbridge are in North East London. It's a deprived area, but we're also pockets of extreme wealth. It's sort of characterised by the narrow streets with cars parked either side. You see on the bottom left-hand side, but it does have some open spaces dotted around. So the population we cover is about 770,000, and we're divided into those 3 boroughs we just discussed. We've got 2 hospitals, King George Hospital, which is a small unit, which is where Health 1000 is now based, and a bigger Queen's Hospital, which is a major trauma centre, and 2 at London Ambulance Outpost, and a number of walk-in centres. When we started with a Year of Care programme, or actually before, in 2008, we worked across the health and social care to develop a vision for what we wanted to achieve, and it aligns very well with what the Year of Care programme was trying to achieve. We wanted person-centred care, which you can see in the centre here, with rings of support. We wanted to bring the hospital services closer to the home. You can see that in the top left-hand corner, bring more of the big acute hospital services closer to home. It was quite an ambitious vision, but it was jointly created by both health and social care and all the local GP federations. And that vision has lasted us throughout this programme. So that vision was first drawn up in 2008, and then we went through a whole host of different programmes: risk stratification, integrated care, long-term conditions management. This is when we started the Year of Care programme. We then introduced integrated case management, rapid response and community teams, and moved towards establishing the complex primary care practice. And in 2015, that became live. So it was January when we first started actually recruiting patients. We had hoped to start in November, but it took a very long time to actually enable us to do the patient engagement and all the back office legal and governance functions to enable this organisation to actually start. I thought to try and make it slightly more interesting, and I'm not going to be able to do this now because we've got some technology problems. I was going to talk you through 2 case studies. So the first case study is Ben and Eileen Eaton, and the second one is Morris. Morris is the one I know particularly well because he's one of the first patients we went and spoke to. And he was a very interesting case and made a radical change to the way we designed the clinical services, because when we spoke to Morris, essentially we realised that it wasn't about the clinical need, it was more about what the person actually wanted to achieve. So in Morris's case, he was very keen to be able to go fly fishing, but all the interactions have been focused around all his health needs, and now he's joined the practice. We haven't actually been able to enable him to go fly fishing yet, but he is now working towards that goal, and that's a big thing. So I know we can't show you the video yet, but we'll look at it later on. He'll talk about his feelings and feedback and how the services impacted on him. What I can do on the next slide is we had a graphic designer come in and capture some of the patient views of the practice. So on the left-hand side of this diagram, you'll see this is as was. So Morris is the one in the bottom left, and you can see his pathway and journey into what he now considers to be a first-class service. A couple of the key points to pick out here are that it wasn't just about Morris. It was the red person represents Morris's son, and a lot of the care for Morris fell onto his son, and it was a big piece of work to enable both the son that this was the right move and Morris, because Morris was actually quite happy with his general practice. He could see no reason to change. He'd been there for over 80 years. But once he was in, he's very, very pleased. And some of the big changes are the amount of time that he has available to meet his needs or to discuss his problems. I think one of our big learnings, which came at the very beginning of this, is how to effectively capture data. So technically, it's not very difficult to join up all the different data sets. And we were lucky that when we started this, it was before the recent PCT and the information governance rules weren't quite as strict. So we had done a lot of the infrastructure work there, and we had a complete data set linked up, including GP, hospital, community and social care data. And we've been to the ethics committee and got approval for that data set. So we're in a very strong position. What we did find is that it was very, very difficult to analyse the data because the data is so big. We had to develop new technologies, and one we implemented, which was most successful, was trying to steal the way Google works and using an inverted index to search through patient records really quickly, so we could do very, very quick analysis in terms of the costs and needs of the patients without having to write long, complicated SQL queries. So at the very start, I think every one of the pilot sites was focused on the top 1% risk, and we were working out what is the cost for that group of patients. And you can see from this Kaiser-type pyramid, we did a lot of work around this and around the costings for those patients. We even tracked 500 individual patients across health, social care, community, and mental health to work out the exact cost of every single transaction that they had, and that was done over a 2-year period. If we look at the next slide, you can see from the initial pilot sites, most of the cost for the different categories of patients were fairly close. There was one site that was slightly outlier, but the rest were fairly close in terms of the actual cost they saw between patients. And that was important. But when we drilled down into that further, on the next slide, essentially what we started to see then is that for us, we were spending a lot more money on community care as we were doing more and more case management to community treatment, and particularly around risk stratification and moving that top 1% into a defined care service. And that's why you can see that cost increase in the community services from 12 through to 14. So when we started to look at how we could make a bigger difference in the future, we started to look at the Scottish model. This was quite a transitional point for us because we started to move away from risk stratification to looking at comorbidities, and where we felt we could have the biggest impact using multi-morbidities rather than just risk stratification. And actually this is the basis of the actual Health 1000 or the complex care organisation, and the cohort that we selected was based entirely on multi-morbidities and not related to risk stratification. This one outlines what we consider to be, after all our research, the best combination of diseases or illnesses to enable us to make an impact on the care for patients. We also wanted to be able to pilot something that was quite small and contained, so we couldn't do it for a very large job because it would be too risky for us as an organisation. So we picked a small cohort. In that case, we chose those that had 5 or more long-term conditions, and we made them from a defined list which we think we could have the biggest impact on. And those are COPD, stroke, heart failure, diabetes, dementia, hypertension, depression. And you can see in the table at the bottom the numbers across the 3 boroughs. So out of those 770,000 patients, there were at the start of this 2,024 that were actually meeting our criteria for this test. And of those, we essentially chose to have 1,000 and then 1,000 as a control sample. And it would basically be the first 1,000 that's enrolled would be the ones that were part of the Health 1000 organisation. So I debated whether to include this next slide, but this one basically shows the number of primary care contacts that the cohort of patients were having. So you can see it's a very significant number of contacts for this particular cohort, and this is in the general practice. So some of it might be prescriptions, but actually when we looked into it in more detail, it's roughly 1 in 12 appointments. So the diagram shows basically on average a patient having an appointment once a week. We think it's more likely once every 2 to 3 weeks, but it's still an enormous amount of contact for primary care physicians. In terms of the other costs that this cohort includes, so this one shows the cost for the 2,023 patients, not just the 1,000, which is why you see a figure of close to 20 million, whereas it's really going to be 10 million for the 1,000 patients. So you can see what's particularly interesting, on the next slide it tells you, so there's a great deal of variation between the patients. So some are having lots of A&E attendances, but actually some are having, in fact, a large number having no acute hospital admissions at all. And that was quite a learning for us because we anticipated that this cohort would be all major users of hospital inpatient activity, because it turns out they weren't. However, what we did see through the analysis is that the cost for this cohort has increased year on year and is now probably almost double what it was in 2007, 2008. And the average cost for this particular cohort of patients was around £10,000, although that does increase significantly if they're in the end-of-life phase. So having done all this, how do we actually go about implementing a new service? And it was extraordinarily difficult, I think, is the one thing I can honestly say about this. We thought it would be relatively easy, but for a whole range of reasons, it wasn't. So the next slide summarises a couple of the initial problems we have encountered. So the first one being financial arrangements. It seemed easy at the start because we secured a large amount of money from the Prime Minister's Challenge Fund, but actually transitioning that money into a new organisation and the arrangements around that were very difficult. The CQC registration is a really big problem because general practice registration wasn't applicable and acute trust registration wasn't applicable. In the end, we had to create a new form of organisation and go through a new form of CQC registration because of the range of services this new organisation would provide, which leads on to a bigger problem, which actually was insurances. One we weren't expecting, but it was very hard to get insurance for the different services that we wanted to provide because it's so different to a traditional GP practice and isn't covered by the NHS insurance policies because it's essentially a private provider. Another one which was interesting was getting membership of clinical commissioning group. Originally it would have been in Redbridge, a clinical commissioning group. There was a long debate about where the organisation should actually sit, and ultimately it resides now in another clinical commissioning group. The other, perhaps the most significant one, actually one of the biggest challenges and probably the most radical we were, is we are deregistering patients from their existing GP practices and re-registering them to this new organisation, which requires that the organisation holds an APMS contract. And that means that based on the current legislation, a GP has to be a director of that company and an owner of that company. And there's a whole range of other obligations that come around the APMS contract. We have managed to solve all those, and it does now hold an APMS contract. And we do have a GP who is a director of the organisation to ensure we can hold that APMS contract. The other problems are how do we recruit the clinical teams and at what point do we recruit the clinical team, because there's a very steep transition between 0 patients and the point where it's actually sustainable, and it's very expensive and costly to move between point 0 and what will become clearer later, about 523 patients. And we still haven't reached the 523 patients, but we have a huge staff in place to try and manage the cohort of patients that we do have to make sure we provide adequate care, even though we have very small patient numbers. So you might think it took a long time to do this, but actually we did this all within 12 months. So it was a very, very compressed timeline, and that's because we were under pressure to meet the Prime Minister's Challenge Fund obligations to spend that money within the financial year, and also to make sure we could show something for the money that we had invested in the service. So you can see we started in May 2014, and then probably by October we had actually had a service that was ready to run. The problem we then had was how do we get patient engagement and patient recruitment, and it took us up until January to actually start that process. And it was in January that Health 1000 actually went live. Next slide. It's probably worth talking about this point about some of the governance issues. So we've looked at various different organisational forms and actually joint ventures where the CCG group partners with the local authority could, and we did a very, very long and thorough engagement with all the different stakeholders in the local health and social care economy. And the output from that was that there would be a complex care programme board which would be established, which had senior representation from the acute trust, the community trust, mental health provider, Health 1000 as it became there, which is a private provider, the voluntary sector, and local GP federations. They wouldn't have any role in the day-to-day operation, but they would have a clear role in setting the strategy and direction, and they would hold the provider to account in terms of its operational delivery. So probably at this point it's worth looking at the next slide, which talks about the staff required to run this organisation. So really from day one we had to have a significant number of staff, and you can see that shown on the left-hand column, which is the whole-time equivalent of startup. The GPs are probably the most significant because as we hold an APMS contract, we have to be open for a set number of hours and we have to provide medical services during those set hours. Unlike a traditional service you'd refer to, which only has to be open for specific periods, we have to be open for a continuous period, which when you have 1 or 2 patients is enormously expensive to operate. We then move on towards, if you like, the whole-time equivalent by month 3. We still have started to increase to reach that, but we are quite low on patient numbers at the moment, so we're still not at those levels. So if I show you the diagram on the next page, which actually is our operational process or clinical model, it perhaps becomes a little bit clearer. So the first 7 boxes, which I can't read on the screen, but the first 7 boxes are all about patient recruitment and how do we get patients into the service. The last few boxes are how to provide the care once they're in, but it's actually getting the patients into the service, into making them aware about it, is a key problem within this actual implementation. And it's boxes 1, 2, and 3, which we found the most difficult. We anticipated that the GPs would be keen to engage with this, but actually, because of the amount of work involved in writing out to patients and then having the discussions about what the new service is, there's actually quite a lot of work for GP practices there, and that's causing us to have a drop in recruitment. We have now worked up methods to improve on that, but it's definitely a key area for anyone trying to look at this, is that recruitment piece, and the amount of work required is a significant area. The fundamental features of this clinical model are that it's basically GP-led. The patient and the carer and the education enhancing self-management are all key parts of it. I think it's fair to say the model has developed, so we started off with a very clinical focused model, and it's only when we started to recruit patients that we realised that the clinical element is quite well covered by existing services. There is fragmentation between providers, but actually the pure clinical bit is quite well covered. What the patients tend to dislike is the lack of access and the difficulty in getting appointments and the fragmentation between the different services and having to repeat themselves. And that's one of the things we tried to address. But once we'd addressed that, it became clear that there was a bigger, more important issue to patients, which is people listening to them, making them feel wanted. And that's why we've done a lot of work with Age UK now. So the initial model is now being supplemented, which you can see on the next slide, by the Age UK Care Navigator pilot. And perhaps focus in the bottom left-hand corner there, where you can see the patient is now at the centre, and the care navigators, and we're currently calling them key workers because we haven't actually got the Age UK care navigators in place, but we are using a resource called a key worker, who is a key point of contact for that patient, and those patients are tending to phone up these key workers or care navigators for conversations, just to basically to remove the loneliness or to guide help. So that's working very well and it's been a big win. I think the real difficulties in trying to implement this, though, always come down to funds. And if we look at the next slide, you'll see that this financial modelling, so we actually had to pay quite a lot of money for some actuaries to come in and do all our financial modelling. I could spend 3 hours talking about this particular financial model, but I really don't want to, and I'm quite sure no one else wants to listen to it. But essentially this screen you can see is an element from the Excel spreadsheet, which is a summary of where the costs of money go. The area highlighted in green basically shows the point at which the service can break even. So we believe that to be 535 patients, at which point it can actually move to a capitated contract. Before that point, it's being funded through CCG and NHS England funds, which come through from the Prime Minister's Challenge Fund, which cover all the clinical costs to enable it to get to the point where it's self-sustaining. And to go to the next stage, you can see we looked at various different models for this. And had quite a few different models to try and get the costs accurate and correct. And what we found on this one is that the blue and the red line were the best match. The red one is the total revenue, and the blue is the total cost, and you can see where they cross over. But we tried moving and decreasing those revenues and costs, and that's represented by the green and the blue line below. This was all done for us by some very clever actuaries, and also ran some various other simulations to check the numbers were correct. But overall, we think we got there to about the right figure for capitation. This next slide goes into a little more detail about the modelling we did around how long an appointment takes, how much GP contact there should be. We basically ran 2 different staffing models, one which was designed by us by University College London partners, and then one which has been subsequently developed by the Health 1000 organisation itself as it learned what the organisation wanted, and you can see those 2 different colour models represented by the different colours of red and green on the chart at the bottom, and the table at the top looks at the different time required for existing patients. The one which we got about was actually the new enrolment process, because actually there needs to be a big multidisciplinary team assessment, which appears to take about 40 minutes to an hour, and that wasn't factored in when we first did our modelling. And that was clearly a big error, because there's an enormous piece of work that has to be done around enrolment before you enter into the operational and standard running costs. And that was a big learning for us, and something that if anyone wants to repeat this, they should definitely factor that in. This is where we are today, and the biggest problem we've got is patient recruitment. And it goes back to the slides we looked at earlier where we had that workflow. It's getting to the patients to be aware of the service. Patients are typically very happy with their GP. And it takes quite a lot before they understand what the Health 1000 organisation is actually offering them. Of those that have now enrolled, we've had lots of positive feedback, and we now have a range of newspaper articles, and actually there is a video which I think you're going to see later which talks about the positive experiences of various different patients. We have had some negative, but they've been operational issues which have been our own fault. So we've had loss of phones, and it's those technical issues which have been a problem for us rather than any sort of clinical issues. In terms of driving up patient recruitment, we now have a clear strategy on how we're going to do that. We've spoken to the local GP federations who have been very helpful, and we've now worked through a plan on how we can support practices and patients who want to become part of this research program and ensure that patient care is improved and the targets met in order to switch over to the capitated budget, which is our specific aim. But we think we will achieve the 523 patients around September, late October time. At that point, we will really have a fully capitated budget operating organisation, which is transforming the way care is provided. The other point which I should just raise here to close off is that this entire programme is being evaluated by the Nuffield Trust. We thought it very important to have a clear independent evaluation who were working from the very beginning, helping us design some of the data we would capture right the way through to the end. And we have a complex care programme board that meets, colleagues meeting monthly, where they sit on that and they guide us in terms of our evaluation. The interim report is due out in December, and then the final report is due out 15 months after that. So I think the big learning for us is the system-wide engagement from the very beginning is critical. If you have one of those stakeholders that isn't fully supported and engaged, it becomes a lot more difficult to implement. We didn't do enough engagement with the general practices. We did engagement with the clinical leads in the CCG, but we didn't do enough grassroots engagement with the GP practices that made our life more difficult at a later stage. We had done lots of engagement with acute social care, but that would be my one learning. Make sure you engage with everybody very early on.